Ok, espero, a mí me salen los subtítulos en español, tal cual Mary está hablando, me lo está
Ujú.
traduciendo, entonces espero que se esté grabando en español, porque ahorita Lupita, aunque la configuración le daba en español, a Lupita le seguía saliendo en inglés.
En inglés.
Chicos, si ustedes en algún momento no pueden desde la computadora, cambien a un dispositivo de celular a ver si ahí les permite ver la traducción en español, ya que es la única manera, como se los envía al chat, de que ustedes lo puedan ver en español, pero si de ahí no pueden, es por la configuración de la actualización que tienen de su computadora con sus dispositivos. Traten de cambiar de dispositivo a ver si ahí pueden ya verlo en español.
If I talk
Listo.
in English, you can already see it in Spanish. Better.
Se puede de otra manera, Vero.
¿Ok?
Bueno, lo tengo yo en inglés, es captions, dice CC, es un iconito que no es, son los 3 puntos, está al lado de grabar. No sé si lo pueden ver en el menú. Capturas, creo que es en español. Ahí se presiona y ahí sale la opción de traducciones. Se pone
Ok, bueno,
el idioma.
dependiendo de las configuraciones
De
que se
la
tengan
configuración.
y de la computadora, porque yo no, por eso yo tengo una Hawaii, en la Mac aparece de otra manera y en las Windows de otra manera. Entonces, por decir, yo les estoy pasando la manera en la que a mí me aparece, pero la que tú compartiste, tal vez quizás tengan otros compañeros la misma situación y puedan
Ujú.
encontrar ese icono, pero es la
Ok.
configuración de su computadora.
Ok. Entonces le digo a Mary que ya.
Pueden continuar. Muchas gracias. Sorry, Mary.
Oh, no problem.
We can continue, Mary.
Okay. So the intrinsic muscles are muscles that have their origin and insertion within the hand. And extrinsics would be that their origin, the muscle's origin, is somewhere outside of the hand and inserts in the hand. And the intrinsic muscles are very important. The intrinsic muscles are going to be innervated by the median nerve and the ulnar nerve. And all the radial nerve, everything that it innervates is extrinsic. And it's also extensors and abductors. And it's just a good way to remember that extrinsic is radial and it's going to be extensors and abductors. So if you want to think about which muscles are innervated by the median versus the ulnar, you can sort of divide the hand in half and say pretty much everything on this side is median, everything on this side is ulnar. So there are a few exceptions, but that's a good starting place. The muscles of the thenar eminence are median, and those are intrinsic muscles. The muscles of the hypothenar eminence are ulnar, they're intrinsic. And all of the interossei, which ab and adduct the fingers, they're all ulnar. So that's the exception. All of those are ulnar. And the adductor pollicis is also innervated by the ulnar nerve. So it's really the only thumb muscle that's innervated by the ulnar nerve. And if you think about it, the adductor pollicis really, it's just like another interossei. Another very important intrinsic muscle is the lumbricals, and the lumbricals does this. The lumbricals enables you to do this. So it's a magic muscle. It flexes at one joint and extends at another joint. That's pretty cool. The reason that it flexes at one joint and extends at the other is that it has a moving origin and insertion. The origin is on the flexor digitorum muscle, and the insertion is on the extensor mechanism. So its origin is on a flexor, its insertion is on an extensor, and it allows you to do this. The lumbricals, the first two are innervated by the median, the second two are innervated by the ulnar. So it follows that rule. So how many times have you seen a patient? I don't know if your students, maybe you haven't seen a lot of patients, but how many times have you seen a patient whose hand looks like this, like a spinal cord injury or a brachial plexus or a stroke patient? And the reason that it looks like this is because they don't have intrinsic function. And specifically, the intrinsic muscle that they don't have is the lumbricals. So the lumbricals is the antagonist to the extensor digitorum communis. So this is EDC taking over, and this is lumbricals. So the lumbricals balances that. And the EDC is innervated by the radial nerve, and it's extrinsic. So it's still working when the intrinsics aren't. So now we'll kind of get that we've got some landmarks. We'll get into the evaluation of the hand, performing an evaluation. So it sounds kind of corny, but you can see a lot just by looking, taking a minute to look at their hand and just looking at the normal resting posture, because the normal resting posture is we sit with our hands, our wrist in a little extension, and our fingers flexed. And sometimes patients who maybe they can't extend their finger all the way and they feel bad about it or think it's conspicuous, but really we don't sit like this. We sit like that. That's our normal resting posture. If you look at the hand, look for atrophy, and that's a thing, you know, when people don't have intrinsic function, then a lot of times you'll see that hollowed out thumb adductor. Look for the color, look at the appearance, look for normal wrinkles. And also, it's really important to see if the patient uses the hand. Sometimes people will come in and they just hold their hand at their chest and they won't use it. You hand them a card and they'll grab it with the other hand. Or maybe they'll grab things, you know, between their fingers and not use their thumbs. So just kind of observe if they're using their hand. And remember to always compare it to the other hand. And I have someone right now who broke his wrist, and he when I tried to see if he could do supination, he looked like this, and I was like, oh no, he's really stuck. But when I checked his other hand, that's just how far he went. So remember, everyone's different, and always compare the other side. So this person, you might think that they're just pointing, you know, the index finger or, you know, for whatever reason, sticking it out. But this person actually had a flexor tendon laceration. And so that's why his finger's resting in that position. Because normally when we rest, there's a little tension on our flexors. And so we're going to rest in that position. So this is functional range of motion. And there's been a lot of studies that have come up with these numbers. And these are actually the numbers that you need to use your arm. And I just think it's important to take a step back when you're working with patients and kind of remember that we don't necessarily need full range of motion. We need functional range of motion. So we don't need our elbow to straighten all the way. If we can straighten to -30, we can do most things in life. We can reach things. We can, you know, pick things up. We don't need full extension, but we do need full flexion. Because we need full flexion to hold the phone, to do a ponytail, to put in the earring. We need full flexion, but we don't need full extension. And with pronation and supination, if you can't pronate or supinate all the way, you can compensate a little bit. So we don't need necessarily full range, but we need at least a 100-degree arc. With wrist flexion and extension, we really don't need full flexion. And if you think about in life, what do you really do with your wrist in this position? There's very little. Even if you scratch your back, you know, your wrist isn't in full flexion. But we do need a little more extension because we push up with things, put things together. In radial and ulnar deviation, we don't need that full range. We need about 40 degrees, an arc of 40 degrees. And we don't need to make a full fist to function, and we don't need to go all the way straight to function. So someone told me this, I didn't make it up, but they said the only time you need a full fist is if you're going to sock someone, and the only time you need to go all the way straight is if you're going to slap someone. But if you think about it, if you're holding something, your fingers aren't all the way bent. So we really, when we work with people, just remember that we don't necessarily need all the way down. We don't need all the way straight. We need them to go straight enough that you can get your hand in your pocket, and we need them to bend enough that they can hold on to most things. So these numbers are here for your reference of just what the functional motion is. And don't always feel like you need to work with people to get perfection. You just really need to get them functional. And I think this is another, just good thing to kind of keep in mind. And more studies are showing this, that many patients after wrist fractures and metacarpal fractures, they don't need that much therapy. And more studies are showing that you can teach them some exercises and maybe bring them back in 2 weeks and see how they're moving. So just remember functional motion, teaching them what to do. So to just kind of get into some range of motion measurements, the elbow is pretty simple. We just line up. We usually line up with a lateral epicondyle, and we measure flexion and extension. That's pretty simple. Pronation and supination is a little bit trickier, and I think it's a little less precise when you do it. But remember, we need the elbow at the side like this. And again, I always measure both at the same time. So if I can't supinate all the way, if I go like this, it looks like I'm supinating all the way. Or if I can't supinate all the way, if I go like this, it looks like I'm supinating. And same with pronation. If I can't pronate all the way, I can lean, or I can bring my arm out like this. So when you measure it, have the elbow at the side. So again, this is a little less precise thing to measure. It's a little tougher, but take the longer arm of a goniometer and line it up vertically, and then this part of the goniometer goes into the and really measure back here on the forearm, because you have motion in your hand. So this is my forearm moving, but my hand also moves some. So put it back on the forearm, line up with the horizontal, and then this goes on the forearm like that. And again, I think it's a harder one to measure, and it feels less precise, but that's about the best measurement that we have. There's an app that you can get on phone, and I think it's called Dr. Goniometry, and it has, you can hold it and do some motions and it'll measure. I've never really used it, but I think that technology will help us come up with a better way, a more standardized way to measure pronation and supination. So with radial and ulnar deviation, we line up with the third metacarpal. So we're at the wrist joint, we're at the third metacarpal, and we're just going to go ulnar deviation and radial deviation. So for wrist flexion and extension, you may, in your textbooks, they may have taught you to do it on the ulnar side or the radial side. But the recommendations of the American Society of Hand Therapists is that you do it dorsally for flexion, and you do it volarly for extension. And the reason is because, remember I was telling you, this is my wrist moving, and this is my fifth metacarpal. So if you do it on the ulnar side, you get wrist flexion, but then are you also flexing that fifth metacarpal? So the way to make sure that you're doing pure wrist is to do it dorsally. I like these goniometers, and they're pretty inexpensive. And so what I do is I just cut them. So it originally was this long, and I just cut it. And the reason that I did is because when you do extension, it's going to come out between the fingers. So you measure wrist extension like this, and you measure wrist flexion like this. So this may be a little bit deep to get into for students, and I know you probably feel overwhelmed with all that you learn. But if you're assessing the wrist and you're trying to decide why the wrist is stiff, You want to know if the stiffness comes from tightness in the joint capsule or whether it's coming from extrinsic or other factors. So this is kind of a way to test whether it's coming from the joint capsule. So it would be capsular stiffness versus extrinsic tightness. So if a person, if you extend their wrist and you measure it, and let's say you get 60 degrees with their fingers flexed, and then you extend their fingers and it's tight and it hurts and you can't get as much extension, then you know that is not because of the capsule, that's because those flexor tendons are tight. So if you get more extension here and as you straighten this, you get less, that would tell you it's because of extrinsic flexor tightness. But if it's tightness from the capsule, then the amount of loss that you would have in flexion and extension, it would be the same in both directions. And that's how you would know that it was a capsular pattern. So what you would have to do is find out, well, what's normal? So you'd measure their other side and say, oh, normally they have 60 degrees extension and they have, 60, okay, let's say 80 degrees flexion and 60 degrees extension. So if you measured on this side and they had 20 degrees loss in both ways, both directions, then you'd know that was tightness from the capsule. And again, that may be getting into too much minutia. Again, there are a lot of different goniometers, and this one is a metal one, and it's very fancy and probably expensive. I don't like it that much because I think it's really hard to read. It's in kind of 5-degree increments. And also this arm is kind of short, I think, if you're going to measure MPs. This is another fancy goniometer, and again, probably expensive. I guess one reason people like this is because it will also measure hyperextension. But I think this is kind of worthless for anything except maybe the DIP, because it's too short, definitely too short at the MP, and really too short at the PIP. So I don't think this is very good. And I like this one. And it's cheap, and I cut it in different lengths. So I cut it like this to do the wrist. And then for the MCP, so that's measuring the MCPs here. I have the arm a little bit long. I cut them both, but I have it a little bit longer. And again, you're going to record extension and flexion. And don't forget that at the MCP, we not only extend, we hyperextend a little bit. And when you record those numbers, if you record hyperextension, those numbers would be a minus number. And you think about, if this is 0 and this is 45 and this is 90, then if you go this way, that would actually be recorded as a minus, the hyperextension. So we would measure hyperextension, and then we would measure flexion of each MCP. And then the PIPs, we're going to measure, they only extend to 0. So we measure how much extension they have. And if they can't extend all the way, let's say the index finger PIP is stuck at about 30 degrees, you would record that as 30. And then how much they go. So let's say they go 30 to 95. So that's how you would record it, 30 to 95, not minus 30 to 95. And some people do that, and I used to do that because I thought of it as minus because I was trying to get to 0. But the proper way is to record it as 30 to 95, or if they're all the way 0 to 95. And same at the DIP. So you're going 0 or whatever their starting position is to their ending position. Some people add those numbers together, and they call that total active range of motion. So they would say, let's say they said the motion here was 0 to 50, and the motion here was minus 10 to 60, and the motion here was 0 to 50, you'd add them together and the total motion would be 300. So, and you'll find in some journal articles that they'll record motion as total active range of motion. So it just depends. The system that we use to document, it calculates that. So, and I mostly tell you that in case you read a journal article and you're wondering what total active range of motion means. So for the thumb, we're going to measure 3 different things. We're going to measure radial abduction. That's coming out this way towards the radius. Then we're going to measure palmar abduction, which is coming out from the palm. And then we'll measure adduction. And another way you can do measurements, let's say that your patient comes in and all their fingers are stiff, and maybe they have arthritis, and you're thinking, I'm not going to really be working on getting all that motion because their fingers are pretty, fixed, but I do want to take a measurement. And maybe you don't have time to measure every joint. So one thing you can do is you can measure the distance from the tip of the finger, from the distal palmar crease to the tip of the finger. So you can just measure this, and you can measure it in centimeters for each finger. And it's just a quick way to measure range of motion without having to measure each joint. Again, always check the other side, find out what's normal for them. Some people have a lot of motion. Some people normally just don't go very far. And when you evaluate range of motion, like for a wrist fracture, you're going to measure the wrist. And you're going to measure for wrist pronation and supination. And you're going to measure the fingers, because a lot of times after wrist fracture, fingers get stiff too. You know that. But don't forget to measure the elbow and the shoulder, because a lot of these people, especially if they come in and they're like this and they've been in a cast for a while, or even a sling, sometimes you see wrist fractures come in with a sling, and their doctor probably told them to wear it the first 2 days, and they won't take it off. They're wearing it all the time, but they'll end up with a stiff shoulder. So always measure the shoulder, just a quick exam, make sure they've got, full motion in the shoulder, because sometimes they get stiff. Remember, your shoulder's job is to put your hand somewhere. So if your hand's out of business, then your shoulder's out of business. Also, some people just normally, have a lot of motion. So some people have a lot of laxity. Some people don't go very far. So always measure the other side. There are some different ways that you can measure palmar abduction, and that's coming out from the palm. One way is you could go again from the distal palmar crease to the tip of the thumb, and you could measure that in centimeters. You could also just do a goniometer on the side to measure radial abduction. Palmar abduction, I meant. Radial abduction's pretty easy. Just put the goniometer on the top and measure that. And you're putting it at the axis of the joint. This was an article that came out. I can't even see it. Let's see. 2022. And just looking at some ways to better measure CNC motion. So what they suggested in that article was to put an X on the first metacarpal and an X on the thumb metacarpal. And then you measure the distance between those two. So when they're in radial abduction, you can measure that, but the middle of the X to the middle of the X. And then when it's in palmar abduction, you can measure the middle of the X, the middle of the X. In this article, they use this gadget. I don't have one, so I just use a ruler. Vera has one. I need to get one. The way to measure adduction, one thing is to just say how far the finger goes. So how far the thumb goes, if the thumb can go to the base of the middle finger, just how far it goes. Another thing is you can measure it in centimeters. So you could put the ruler at the base of that IP crease and then go over to the distal palmar crease under the small finger and measure it in centimeters. Another thing that you're going to see in the literature a lot, it's called the Capanghi scale. And it's pretty easy. So the way I remember it is I say that this is a 3. And again, this is just the way I remember it. So if this is a 3, tres, cuatro, cinco, seis, and then you go as you count, you count the wrinkles. So it's 3, 4, 5, 6, and then the creases 7, 8, 9, 10. So 10 DS is the distal palmar crease under the small finger, and that's all the way, and that's full motion. So if you wanted, one way to measure it is if your patient, the farthest their thumb can go over is touching the tip of the index finger, you could say it was Capanghi 3 or 4 or 5. You could record it that way. So like I said, I remember that 3 is this. So 0 is just kind of where the hand rests. And then then 1 is that the tip of the thumb touches the radial side of the proximal phalanx, the middle phalanx, and 2 is the radial side of the distal phalanx, and then 3 is tip to tip. Because when they start out, sometimes they can't even bring it into opposition. They're sort of coming in from the side. So that's 1 and 2 coming in from the side, and then 3 is the tip. So that's just kind of how I remember it. You could also just say in your note, patient can touch the tip of the index finger with their thumb, or patient can touch the tip of the long finger. And that way, everybody's communicating. Maybe that's a better way. If you want to see if their EDC works, you're going to have them extend all of their fingers. And if you want to see, remember the index finger has its own extensor and the little finger has its own extensor. So if you have them hold these 2 fingers down, then you're kind of looking at EIP, which is the index, extensor indicus proprius, and the small finger extensor. And remember, we talked about the flexor digitorum superficialis. It just flexes the middle joint. And we talked about how the profundus is the one that flexes all 3. And if you really want to test like profundus strength, you can have them make a fist and get your finger in there and pull on it. The superficialis is innervated by the median nerve. All of them are. But on the profundus, these 2 are innervated by the median, and these 2 are innervated by the ulnar. So if someone has some ulnar nerve weakness, they might make a fist. But if you tested the profundus on the index finger, it'd be strong. And if you tested on the small finger, you'd see weakness, and that would tell you had some ulnar nerve weakness. We all know the 0 through 5 for grip strength testing. For strength testing. The problem with that is it's subjective, and what's a 5 for me is not going to be 5 for some big, strong guy. So it's kind of a hard scale to use. We still use it, of course, but I think it's a hard one to use. Another thing when you're testing strength is to just kind of isolate different muscles that are innervated by different nerves. So you might look at thumb flexion, and that the sole flexor of the distal phalanx of the thumb is the flexor digitorum, flexor pollicis longus, and that's innervated by the median nerve. You can look at the flexor digitorum profundus strength, and you know what that's innervated by. And if you want to test the superficialis, you're going to hold the other fingers in extension. And if you want to test the interosseae, you know, you would have them spread the fingers and you would resist it. And for the lumbricals, just have them assume this position and resist it. If they can, assume the position. Remember on the wrist extensors that when you extend your wrist, it tends to go towards your thumb side, to the radial side. Just do it. Like extend your wrist and you see it naturally goes to the thumb side. And when you flex, it naturally goes to the small finger side. So you have more, you have 2 radial wrist extensors and only 1 ulnar wrist extensor. And that's why it goes that way. So kind of look at that. You have wrist extensors, muscles that extend the wrist. But remember the EDC that we talked about that's radial nerve innervated, and it's the extensor of the MCPs. Well, it can also extend the wrist, but it only extends it to neutral. It cannot extend it past neutral. So if you're testing grips, if you're testing the strength of the extensors, you push down on it, and if you start to see that, you know they're using the EDC. And if you really just want to see the strength of the wrist extensors, have them make a fist and then resist it. And then you know you're only looking at the wrist extensors. Test the, if they can extend the tip of their thumb, because that's the extensor pollicis longus. And that tendon can become ruptured after a wrist fracture. So it's always good to see if they have that working. You're going to hear about this a lot in the literature, and it's called the dart throwers pattern. It's really a thing that everyone's into. But basically, the dart throwers pattern is just the motion that you would use if you threw a spear or a dart. And so it's wrist extension and ulnar radial deviation and wrist flexion and ulnar deviation. And it's the most stable pattern kinematically. There's minimal scaphoid and lunate motion, and it's the most functional pattern for occupations. And some people, if people have a tear in some of their carpal bones, people will make them a splint that kind of keeps them in that dart throwers motion. I don't know how effective that is, but I've made them before. We'll talk a little bit about grip strength. And I don't know if you guys see anybody who has work comp or other injuries that might make them want to not give their best effort. And so I think I may just kind of skip over that and kind of talk a little bit more about how to do grip and pinch testing. And again, all of this is there for you to look at later if you want to look at it in more detail. I don't know if you guys have dynamometers in your clinic. It's nice to have an objective tool to measure. The dynamometer has 5 rungs that you can put it on. This one, this one, this one, this one, and this one. So the standard rung to use when you're measuring grip strength is the second rung. So just put it on the second rung. And then the standard way to measure is that the arm is at the side, elbow is at 90, forearm is in neutral, and you have them squeeze. And we have them squeeze 3 times, and then we have them rest a minimum of 15 seconds between each trial, and then you average the 3. So that's the standard way to do grip strength. I have someone right now, and she has such a stiff hand, and we've worked and worked, and I don't think she'll ever get this, but she can come down this far, and she's actually pretty strong coming here. And when I test her on the second rung, she can't do anything because her fingers just won't come down that far. So on her, I took it out to the third rung, and she had good strength because her fingers didn't bend that much. So you don't have to do it on the second rung. You can do it on any rung that you want to do it on. You just need to put in your note which rung you did it on. So if you have a man, he's got a great big hand, maybe you want to do it on the second, the third, or the fourth rung, but you need to write down which one you did it on. And if you have someone who has a really small hand, maybe you want to do it on the first. But it's just important to write down which hand you did it on, which rung you did it, so the next person will know. And always test the other side so you can compare. Usually the right hand, if you're right-handed, will be a little bit stronger than the left. So this is for pinch strength, and I don't know if you guys have these in your clinics. They're expensive. I think everything in medical is expensive, more expensive than it should be. So there are 3 different pinches that we do. One of them is 3 fingers, the thumb on the bottom and 2 fingers on top. One is just 1 finger on top. And then one is a lateral pinch with the thumb to the side of the index finger, like that. With all of them, same thing as the dynamometer. We're going to have the hand at their side, the wrist in neutral, and we're going to have them pinch. And we're going to do 3 trials. And when you do the pinches, have them have their other fingers flexed. So when you do the tip to tip, have these flexed. And if you do the tripod, have these fingers flexed. Because sometimes they've got their other fingers, up in the air, or they might want to put their other fingers on top. So just have those flexed. If for some reason you don't want them to see what their measurement is, you can turn it over and they can't see it. And that's more in people that you feel like maybe aren't giving you a good effort for whatever reason. I don't know if you see people like that. Anyway, same thing, average the 3 trials, test both sides. This is another test that I think is an interesting one, and especially for someone who had a wrist fracture, is you might want to be able to see how much weight that they can bear through that fractured wrist. And again, once they're far enough post that it's safe for them to weight bear. So what you do with this is you'll have them stand and lean against the table, and you would have the table between 74 and 76 inches high, and the shoulder at around between 10 and 40 degrees flexion, and the elbow, between 0 and 40 degrees extension, and the hand and wrist just in a comfortable position. And then turn the goniometer over. I don't know if you can see that. And then you try to see how much weight they can put through it, comfortably put through it. And you might have a patient who loves yoga, and they want to know if they can get back to yoga, or when they can get back to yoga. Or maybe someone who works out in the gym and really wants to do push-ups, or even just push with machines. It's just kind of a way to let them see what kind of progress that they're making, with their ability to weight bear. I think this is interesting. So you tend to think that the grip strength, that it should be the same. So if yesterday I squeezed it and it was 65 pounds, then it ought to be 65 pounds today. that it, you know, that it would be constant, but really the grip strength changes. And it changes. In this study, they found that it was highest at 10 a.m. and then it dropped off in the afternoon. So just kind of remember that people's grip strength is going to be a little bit different day to day, and don't read too much into it. If on Monday their grip strength was really high, and then it's a little bit lower on Wednesday, because it does change. And I always say to people, it's different every time you do it. And if you think about the basketball player, they don't hit the three-pointer every time. Our muscles are different. They don't perform the same every time. So again, if we want to test the lumbrical strength, we'll ask them to make this position, and then we can resist to try to test lumbrical strength. Does anybody know what this position's called? It's called the intrinsic plus position. And if you can make this position, it means that your intrinsic muscles work. And which intrinsic muscle specifically is this? It's the lumbricals. So on sensory testing, this is kind of the hierarchy in terms of difficulty. So at the bottom of it is just touch. And so we just want to know if they can feel things. If you have the Sims-Weinstein monofilaments, it's just fishing line. It's monofilament, and there's different thicknesses of it. And the amount that you push down enough to make the fishing line or the monofilament bend. That's how much pressure that you do. And there's 5 different levels. So I usually start with the second. The lightest one is very, very light. And in fact, if I touched you and you weren't really paying attention, if you were doing other things, you might not even notice. It's very, very light. So I usually start with the next to the lightest, just to kind of get them so they can get a feel for it. And I always start on the other side, and with them looking, and I say, can you feel this? Can you feel this? And once we've established that they can feel it, then I go to the affected side, and you don't want them to look. So you tell them, don't look. And you say, can you feel this? And it's either yes or no. So sometimes I'll do it and the patient will say, oh, I barely feel it there. Oh, I really feel it there. Barely feel it there. Either they felt it or they didn't. So don't worry about whether they barely felt it or they felt it a lot. It's just yes or no. And remember the digital nerves, the sensory nerves, run on the sides. So when you test sensation, you would want to test on the radial side and the ulnar side. And it's important because, with the median nerve, with carpal tunnel, it's going to be the volar side of the thumb, index finger, and long finger, and the radial side of the ring finger. And then on the ulnar side of the ring finger is the ulnar nerve. So it is important, if you're testing sensation, if you think their digital nerves are affected, that you do it, that you test each side. And some people use vibrometers or, tuning forks, and I never really do that. But those are the 2 lowest levels of sensation. And then the next one is discrimination. So you can use these things, and I don't know if you guys have these, but they're 2-point discrimination. And you tell them, you ask if they felt 1, or if they felt 2, or if they felt 1. And I tell you, I think my experience is people have a hard time getting this, and it's frustrating as the examiner to do it. But you could make one of these. You could make it. You could bend some paper clips and just measure the distance and make one. So the next higher, the first one at the lowest level is just touch, and the next one's discrimination. And then a higher level is identification, and that's just stereognosis. Can they feel something and tell you what it is? And one of the tests that you can do for that is called the Moberg pickup test. And have people heard of that? I'll just show you, since we're having fun. I'll show you on YouTube. So let's see, where's that? Okay. I think it's over here. I want to search. Oh. I think it's over here where I search. No. Okay. I'm going to have to make these go away. Okay. Sorry. I think where I search is over here behind these faces. So that's why I'm having a hard time doing it.
Of what?
So I'm trying to search in YouTube because I was going to show a video of the Moberg pickup test.
Oh, so you want to take the PowerPoint or what?
Well, let's see. So how do I get rid of the things over here?
I think if you put on the PowerPoint escape, it will make it smaller.
If I do, so what do I do?
In the escape,
Wait, let me see. Is this it? This is it. I found it. My bad. Okay. I was going to say, YouTube is a great place to find all the tests, provocative tests, just a great resource. I looked to see if they had YouTube in Spanish, and I didn't see it. And so maybe I need to look somewhere else, or maybe you guys know. But
no offense, but if you still think stocks, real estate, or crypto are the best passive income investments,
in this video, we will be talking about the Moberg pickup test. The purpose of this test is to assess the dexterity.
it's not showing in the screen.
Wonder why. It's on my screen.
Maybe you have to take out the PowerPoint.
Oh, that gets complicated.
Yeah.
Well, shoot. So what you do on the Moberg pickup is you would have 12 objects, common objects. So a paper clip, a safety pin, a key, a coin, a nut or a bolt. And you have the patient, first they pick them up with the unaffected hand. You have the objects on that side and the container here, and you have them pick it up and put each one in the container one at a time. Then you time them, and then you have them do it with the affected hand one at a time. Then you have them repeat without looking. So put a blindfold on or put them behind a curtain and time them. So that's a stereognosis test. Okay, so let's see. How do I get out of here? Okay, I'm going to try to X out of YouTube, hopefully. Okay, good. That worked. The other thing for identification is just stereognosis. Put something in their hand, have them tell you, what it is. Another way to test sensation is and this would be more for a child who can't really, respond to the other tests, is if the skin is not innervated, it won't wrinkle. So you could soak their hand in water, and some of the tests say that you would soak it for 30 minutes, but that's a really long time, and especially for a child. So I was talking with some hand surgeons who were assessing sensation in children who had syndactyly surgery, and they would just wrap their hand in some wet gauze and come back in 10 minutes. And that's a way to tell that if the skin is not innervated, it won't wrinkle. If you buy this 2-point discriminator, it will have directions on how to use it in the box. And also you can watch a video on YouTube. And if you don't have that, then you can refer back to this PowerPoint. But again, it's pretty easy. We start with a 5 millimeters. That's normal. You don't need to go below that. So that's this one. And you just, without them looking, you say, do you feel 2 or 1? And again, you go on both sides. Apply it for 3 seconds, and the amount of pressures you put to where it blanches. So again, those are the directions, really easy to use. And these are the monofilaments. Do you guys use patient-reported outcomes studies? Do you use the DASH? Do you have patients use the DASH, fill out the DASH?
Yeah, some patients, not most of them, and not in all of the, the rehab centers here. Not many of them use the scales.
We pretty much, every patient fills out some patient-reported outcome measure. And the quick DASH is the one that we use a lot. It's disabilities of the arm, shoulder, and hand. And there are a million, there are probably an infinite number of different patient-related outcomes measures. And again, the patient fills it out. It's just asking them, can you open a jar? Can you wash your back? Things like that. And one of the important things about those is in the literature, when you read about how effective a treatment is, a lot of times they'll base the outcomes on DASH scores. So they'll say, we did carpal tunnel releases on half the people, and half the people we didn't. And after a year, we had them fill out the DASH, and the people who had the carpal tunnel had higher DASH scores or whatever. So they're important, very important in gathering data. And you'll see those patient-reported outcomes in a lot of things. And again, there are different ones for, just about anything. There's some for tennis elbow, and some that are more for people who have work comp injuries, and some that for people that have more pain. So I think that we'll be using them more, in the future. I don't know if you guys do pain assessments. That's something that we do a lot of, and they make us do a lot of. And the main one that we do is just the scale 0 to 10, with 0 being no pain and 10 being the worst pain that you could ever have. And I tell people, a 10 is take me to the emergency room. I think I'm going to die. 10 is you're yelling, screaming, laying in the floor. It's the worst pain you could ever have. And then I'll say, well, what is your pain? And if they say, well, mine's a 10. Well, if you're calmly sitting there and you say, yeah, it's a 10, it's probably not a 10, because I just said a 10 is the worst pain you could ever have. So if a patient says it's a 10 and they don't seem like they're in any distress, then that's something that you should note in your evaluation. You should say, patient reports pain is a 10, but they're not showing any behaviors that suggest that they're in a lot of pain. And again, you know, we would do that at the initial eval, and we would do it again at checkup visits. There's also some questionnaires that they can fill out, the McGill questionnaire. Another assessment of pain is like a body diagram where they would mark where things hurt. And another test is allodynia, which allodynia is exaggerated pain to a non-painful stimulus. So it's where you take one of the monofilaments, and it's one of the thicker ones, the 15 milligram, and you would touch them and they would report that as pain. That's allodynia. And then I always, again, I describe behaviorally. If some people walk in the door and they're just holding their hand like this and they're crying, and you can't even get them to put their hand on the table. And those are things that you're going to notice. You're going to say, well, this is a patient who really has a lot of sensitivity or a sensitized nervous system. So just kind of describe behaviorally what they're doing and if they refuse to use their hand. So some dexterity tests. And again, I was going to show you YouTubes of these, and I don't think YouTube's going to work. So 9-hole peg test, it's a real easy test. And if you don't have one, you know, you could make it. This is the 9-hole peg test. And you time them putting the pegs in one at a time and taking them out. So it's the time as soon as they touch the first one, and then when they take them all out. And it's an easy test, and easy to administer, and easy to explain. And also you could use it for all ages. You could use it for children too. This is another test that probably every OT clinic in the US has, this Purdue pegboard test. And most people use them as a therapy exercise, but it's actually a test. And it's got the little metal things that you put in. And it has washers, and it really tests fine motor. It's a pretty hard test, and it's got good normative data if you want to use that. Another test is the Minnesota rate of manipulation, and it's these discs. They look like kind of like thick poker chips, and they're orange on one side and black on the other, and they turn them over, and it's tedious to give. Another thing is you could just describe in-hand manipulation. So you would say, you know, they can pick up 3 coins in their hand, and then they can move those coins back out of their hand. And I think that's a really simple, good way to do it. Block and box test. They pick up a block from one box and hand it to the other. I don't see those as much. I see these two, people using these two a lot. The NIH, National Institutes of Health in the US, they recommend the 9-hole peg test because it's a simple, inexpensive test that you can use throughout all the ages. So we'll talk a little bit about provocative tests. So provocative tests, we're going to test different structures. And I think one of the most important things when you do these tests is you're going to ask the patient, you're not going to say, does this hurt? But you're going to say, does this reproduce your symptoms? So again, we're not looking for, you know, if I drop a brick on your foot, obviously that's going to hurt. But what we want to know is if that reproduces, you know, their symptoms. And don't give them the answer. So if you're doing the test for cubital tunnel and you're tapping on that ulnar nerve, you want to say, what does this feel like? And if you tap on it and they say it hurts, then that's not a positive to nails, because a positive to nails is that it shoots electricity out. So when you tap on it, don't say, does this send electricity out to your fingers? Because they'll say, yeah. Say, what does this do? And they need to give you the answer. You may want to save some of the more painful tests for later. I don't know if any of you guys have had de Quervain's, but it's the tenosynovitis here. And the test for it is moving your hand like this. Well, when I had that, it hurt so much. It made my whole hand hurt for the rest of the day. And so if that was the first test you did, everything that you did afterwards would hurt. So kind of try to save the more painful ones for last. Remember that on anyone, if you push on a nerve, it's going to hurt on anyone. And some people, like I'm pushing on my radial nerve right now, and it hurts. Some people, it will hurt a lot, and some people, it won't hurt very much. And if we were all together in a classroom, we could push on each other and kind of see. But so if you push on someone's nerve, it's going to hurt. But if you push on someone's tendon and they don't have tendonitis, it won't hurt. So just remember when you're pushing on nerves to just kind of think about how much it hurts, because it's normal for them to hurt. And just another thing to kind of think about in the hand, you know, in other areas of the body, we talk about things as being medial or lateral. So like that's your medial epicondyle and that's your lateral epicondyle. But in the hand, when we talk about structures, we talk about them as being either ulnar or radial. And maybe that's because when we pronate and supinate, we kind of lose the medial and lateral orientation. But for example, on your thumb, this is your radial collateral ligament, and that's the ulnar collateral ligament because it's on the ulnar side of that joint and the radial side of that joint, as opposed to the medial or lateral. So it's radial and ulnar in the hand. I don't know how much you guys have to read articles, studies in the literature, but if you do, and you're trying to make sense of them, it can feel a little overwhelming when they talk about sensitivity and specificity and positive predictive values and all of those things. But just remember that sensitivity is the test's ability to rule out something. And specificity is the test's ability to rule in. So you can think of, you can kind of remember it with specificity being snout, SN rule out, and specificity being spin, it rules in. And those numbers, the way they get those values is based on studies. So they'll do a randomized controlled study. And so if you had, let's say, 20 participants in your study, and 10 of them had de Quervain veins and 10 of them didn't, and we did a test, we did Eckhoff's test for de Quervain veins, and we found that everyone who had it tested positive, then it would have a very good sensitivity because it captured everyone who had it. So its sensitivity score would be 100% if everyone did. And then if this test also for the people who did not have it, if they all tested negative, then it would have a very good specificity. So that would be high numbers. It would be 100%. Well, you're never going to see 100% on anything. And if you do see 100%, it would make you skeptical of the quality of the study. But typically, when you look at studies for sensitivity and specificity, positive predictive values, negative predictive values, you're always looking for higher numbers. The higher the number, the better the test. You know, 80%, 90%, those are real good numbers for to look for. Now, the one thing that's a little more confusing is likelihood ratios and positive predictive values. So just remember, I mean, you'll just have to remember this, I think, when you look at them, is that if it's if the positive likelihood ratio is greater than 10, that's good. And if the negative likelihood ratio is less than 1, that's good. So those you're just going to have to remember when you're looking at those tests. And if you're like me, when I look at journals, I read the abstract first, and if it's interesting, I'll read the whole thing. But a lot of those values are in the abstract, so it can help you know which test to choose, which one has the higher sensibility, specificity, and predictive values. And some of the tests that have good predictive value are Phelan's test and tenelles. We're going to talk about all these. Carpal compress, scaphoid shift. So this is a nice little drawing to just kind of show you that how they calculate sensitivity, specificity, and predictive values. So just remember what you want to see is that you want to see for the people that have the test, you want to see high numbers of positives, and for the people who don't have the test, you want to see high numbers here. So some provocative tests. You're going to see a lot of people who have CMC osteoarthritis. So osteoarthritis is wear and tear arthritis, and if we live long enough, you're all going to get it. It's inevitable. And the joint, if you have osteoarthritis, the joints you're going to get it in are the base joint of the thumb, the CMC joint of the thumb, and the IP joint, the tip joint of the fingers. That's osteoarthritis. Now, if you have rheumatoid arthritis, which is a disease, and you probably won't get that, rheumatoid generally affects the MCPs and the wrist joint. And so with rheumatoid arthritis, you see people's fingers going into ulnar deviation like that. But with osteoarthritis, we see it in this joint, and it affects a lot of people, and it can be very, very debilitating. So some tests that we can do to see if people have CMC arthritis. One typical one that we do a lot of, it's called the CMC grind test. So what you would do is you would take that first metacarpal like this, and you would just push it into the joint like this, and you're just kind of grind it around. And the idea is if there's arthritis in that joint, it's going to be painful, and you might even feel some crepitus or some crunchiness. So that's the CMC grind test. And if you look at the sensitivity and specificity scores on that, it has a pretty high specificity, but not so great sensitivity. So another test of CMC arthritis, it's called the pressure shear test. And you just apply pressure, take that first metacarpal and apply pressure downward and rock it over the first metacarpal. And that test, if you'll look, that test has a lot better predictive values. The sensitivity's 99%, specificity 95%. So this is really a better test for CMC OA. But if you ask most therapists tend to do the CMC grind, but actually this pressure shear is a better test. And it really is just pushing down on that first metacarpal. And a positive test is that they would report pain. And some other tests with lower value are just MCP flexion test and MCP extension test. So you can see the most valuable test is going to be the pressure shear. And your therapist that you will go and be your supervisors on your field work are probably going to do the CMC grind more than this one. So some other tests, a test for intrinsic tightness. So extrinsic tightness is that the extrinsic muscles, and those are the ones that have their origin outside of the hand and their insertion in the hand, flexors and extensors. And the intrinsic muscles that their origin and insertion is in the hand. And the test for intrinsic tightness is if you make a fist, a full fist, and your eyepiece are pretty supple, then you extend your MCPs, then flex your eyepiece. Everyone do it. You're tighter. You can see your eyepiece are a little bit tighter when your MPs in extension versus here. And if people have a lot of tightness and you can't flex them all the way, that would be intrinsic tightness. So remember, everybody has a little intrinsic tightness, but your patient would have a lot of intrinsic tightness. No tightness here, but tightness here. That is the test for intrinsic tightness. Then the test for extrinsic tightness. So normally, when you flex your wrist, your fingers go into extension. When you extend your wrist, your fingers go into flexion. And that's just because of the length of your flexor tendons. So if you, and again, compare both sides. If you extend the wrist and you start to bring the fingers back and they're painful or they will hardly go compared to the other side, then you know they have extrinsic tightness. And the same for the, when you're stretching the extensors, flex the wrist, then start to flex the fingers, compare the other side. And if they have more tightness or more pain, then you know they have extrinsic tightness. Another test is a test that we use with boutonniere. So with the boutonniere deformity, it looks like this, with the PIP flexed and the DIP in hyperextension. And if it is progressed, if the boutonniere deformity has really progressed, they'll start to have tightness and flexing that DIP joint. So with the PIP straight, you'll have them flex the DIP joint, active and passive. And if it's tight with the PIP extended and not tight with it flexed, then that's a tightness, oblique retinacular ligament tightness. So another test is Watson's test, and this is a test for the scaphoid bone for the ligament integrity. And we already talked about that test. And what it is we talked about how to find the scaphoid bone. So when your little finger kind of points to it, that'll get you in the ballpark. And when you're in radial deviation, the scaphoid bone sticks out. And when you're in ulnar, it goes away. So that's what it's normally supposed to do. So in Watson's test, you have them go into ulnar deviation, put your finger on it, have them come into radial deviation. Then when you let go, there's a painful clunk. And that would mean that the ligament that stabilizes the scaphoid is torn or at least frayed or attenuated. Resisted middle finger extension is a test for a median nerve entrapment in the FDS arch. And that's resisted middle finger flexion. Resisted middle finger extension is a test for the ECRB. And if you ever want to, try to find the ECRB, just have them tap their long finger, and you can see the ECRB jumping up. And that's important in tennis elbow because a lot of the studies show that the ECRB is really a problem with tennis elbow. So if you are doing some things for someone with tennis elbow, you want to target that muscle. That's a good way to find it. Resisted pronation is a provocative test for median nerve compression or pronator syndrome, and resisted supination would suggest supinator syndrome. And then one of the most important provocative tests is the Tinel's test. And that's just when you tap on a nerve. And if you tap on a nerve and that nerve is hypersensitive, then what the patient will report is electricity. And again, people are going to have different levels of this. And some people, it may be very strong, and some people in normal population, they can still have a positive Tinel's, but not as strong. And when I tap on it, I feel that electricity going out. So Tinel's, tap on the nerve, electricity. So either the ulnar nerve, or you can tap on the median nerve at the carpal tunnel. The thing about the median nerve at the carpal tunnel is it's pretty deep. It's underneath that flexor retinaculum, and it's deep in the carpal tunnel. So people have to have a pretty sensitized nerve for you to get a positive Tinel's there. You get it more here because it's more superficial. So again, the sensitivity and specificity for the Tinel's for the carpal tunnel, it's just 34%, and for the cubital tunnel, it's 54%. So either way, by itself, it's not a very good test. It would just be part of the other tests. And remember, you're going to do several tests for what the problem that you think someone has, and not just rely on one test. Again, this is just a picture to show you the test for intrinsic tightness, that you would see more tightness with the MPs extended than with the MPs flexed. This is a fun test, and I have YouTube videos, and since I can't screen share when I pull up YouTube, I won't be able to show them to you. But I would encourage you to look this up on YouTube. It's called the Scratch Collapse Test. And it's really, really interesting. And if you look at the YouTube videos, you'll see actual patients that have it. So what the test is it's any neural tissue that's sensitive. So it could be at the cubital tunnel, it could be at the carpal tunnel, it could be, nerve entrapment in the neck, anywhere that you have neural tissue that you feel like is very excited or hyperexcited. So what you do is you'll test external rotation with both arms. So, hey Joe, can you come up here? I'm getting my husband so he can show. I was going to show you the YouTube, but it didn't work out. So we won't get your face. Okay. Let's see. Vacuum up just, yeah. Okay. So we're going to resist. I'm going to have his elbows flexed like this. So I'm going to resist external rotate. I'm going to apply an internal rotation force. And so don't let me move you. Okay. Then I'm going to scratch some neural tissue. So you could either do the carpal tunnel, or you could do the cubital tunnel, or you could do a nerve entrapment in the shoulder, wherever you think the problem is. So I'm going to do the ulnar nerve. So I'm going to scratch his cubital tunnel, and then I'm going to repeat. And if he has weakness, if he has some ulnar nerve weakness, you'll see it fall. And in fact, when you do the test, when you see it on YouTube, if they have it, it just, you can relax. It just falls in like that. Now, when we did it on him, you saw he had a little bit of weakness. Thank you. But I would really encourage you to look at the YouTube videos because it's really a cool test. Again, sensitivity and specificity aren't great. They're around 65, almost 70, and almost 65. And it would just be one test. You do a lot of tests. But it's a fun one to try. And if we had a lab, if we were all together, we would try it on each other. So another good provocative test is, and something that you'll see a lot of, is de Quervain's tenosynovitis. And again, remember we talked about the extensor retinaculum that comes across, and it's what holds those extensor tendons, just like the flexor retinaculum holds those flexor tendons. So when you flex, they're not sticking out here. And when you extend, if you didn't have something to hold those tendons in place here, then they would come out. So the extensor retinaculum comes around, and it creates some areas that are tight. And one of the most common ones where you have compression and tightness and inflammation is the first dorsal compartment. And you can see mine really well. It's here, right here. So it's on the radial side of the wrist. So what gets that stretched, obviously, is when you go into ulnar deviation and you flex the thumb, then obviously that's going to stretch that area and stress that area. So just something to think about. If someone has tendonitis, they're going to feel pain when you resist the motion. But if they have tenosynovitis, then they feel pain with stretch. So again, this is a tenosynovitis, the de Quervain's is. So the test that most people think of, and most people would call it Finkelstein's, is you have the patient do their thumb here, grab it, and go that way. And if If that hurts and reproduces their symptoms, then that's positive for de Quervain's tenosynovitis. And everyone calls that Finkelstein's, but actually that test, people call it the wrong name because that's actually Eckhoff's. And the Finkelstein's test is a passive test. So with Finkelstein's, I mentioned before that I had this, and I had it right after I'd had a baby. And it's actually 30% of the women in postpartum have de Quervain's. And some places in the literature call it mommy's thumb. And there's various reasons why they have it. Part of is doing childcare, and part is just ligamentous changes that we have as a part of pregnancy. But if I did that, it would hurt the rest of the day. And I've had patients who I've tried to do this test with, and they say, I'm not going to do it. It hurts. I refuse to do it. So that's Eckhoff's. So Finkelstein's is just a gentler version of this. So what Finkelstein's would be is you would have their hand hanging over the side of the table and then just let it fall into ulnar deviation. And if that hurts, then you say the test is positive and you don't do any more. But if that doesn't hurt, then you would gently start flexing, moving the thumb into flexion. And as soon as it hurt, you'd stop because it was positive. The test was positive. So again, this flares them up. This makes them hurt. But this way, you can kind of gently move it a little bit and stop as soon as they start to feel pain. So this is actually Finkelstein's, and this is de Quervain's, but they're both the same thing, ulnar deviation with thumb flexion. So there's another test. And it's called the what test? And that's wrist hyperflexion, wrist flexion, thumb hyper extension. So it's another test for de Quervain's. And they flex their wrist and bring their thumb up like this and move side to side. And it would reproduce the symptoms. But again, this is where it's important to think about those specificity, sensitivity values, because this is an example of, I think, where you would want to combine some of those tests. Because on the Eckhoff's, you've got really good specificity. Trying to make that arrow get big, but not very good sensitivity. And on the what, you've got really good sensitivity, but not very good specificity. So this is an example of using both tests and the importance of kind of knowing those values. So another really important thing that it's not very common, but I think it's so important that you should know is patients will be referred to you with a diagnosis of wrist pain or wrist strain. And those are really kind of vague diagnoses. They're not really good diagnosis. And so many times it's up to you to figure out what the problem is and to do some of these provocative tests. And sometimes a patient will break their scaphoid bone. And it's a terrible, terrible thing if they do. It's a very debilitating injury. Well, what happens is they go to the doctor and they fell and they hurt their wrist. And the doctor x-rays and they look at the radius because that's a wrist fracture. People break the radius. And the radius isn't broken. They said, well, you didn't break your wrist. You're fine. But what happens is these scaphoid fractures are commonly missed. And they're just not easy to see in early x-rays. Now, when the patient comes back 2 months later and their scaphoid died, it got avascular necrosis, then you see that pretty obviously on the x-ray. But the problem is it's too late then. They're not going to have a good outcome. They're going to have pain for the rest of their lives. They're going to have limited motion. They're going to have limited strength. So it's a pretty devastating thing to happen. And again, it can be missed, and many times is missed when people have an injury because the fracture doesn't show up in initial x-rays. So it's really important that you do some tests if someone comes into your clinic and they have pain in their wrist, and especially in the central wrist, to do some tests and see if it could be a scaphoid fracture. And one of the tests one of the things is you would just look for edema in the snuff box. And remember, we talked about how to find the snuff box, that's the EPL here, and then the 210 is in the first dorsal compartment, and then the snuff box is right there. So it would be swelling or edema in the snuff box, and also just tenderness at the scaphoid tubercle. And you all know how to find that now, because you're going to flex your little finger, and then you're going to find that scaphoid. Remember, it goes away in ulnar deviation, prominent radial deviation. So they would have tenderness there. And then the other test is just axially loading. And axially loading means that you push a joint together through the axis of the joint. So that's the same test actually as the CMC grind, which we talked about. That's taking that first metacarpal and just grinding it in. And so if you look at those tests, the sensitivity and specificity, the numbers are really low for each of those tests individually when you look at those. But if you do all three of the tests, then the sensitivity is very high. So that's a good example of looking at those values and combining these tests. But I would really encourage you, if someone comes to you and they have a diagnosis of a wrist sprain and they have pain in that area, to do these tests, and then get in touch with the doctor and let them know, that you suspect it might be a scaphoid fracture, and they'll be glad that you told them. Because if they do end up with a avascular necrosis of the scaphoid, the only remedy is really salvage procedures. And one of them is that they just take out the whole proximal row of the carpal bones. And again, that person would not get full motion. They would not get good strength, and they would probably still have pain. So it's pretty devastating. And this is just a patient who had a proximal row carpectomy. So be a hero, do the tests, and find it before it turns black and dies. So some ways to measure swelling is one thing is you can do a volume meter, and I don't know if you guys do this anymore. People used to use this a lot in the US, and now no one really does. And I don't know why. I think maybe no one wants to clean it afterwards. But what you do is you have them stick their hand in there, and there's a bar, and it goes between these two fingers, and you just measure how much water they displace. So that's one way to measure swelling. Another, this is I think the most common, is just circumferential measurements. So whatever joint or area is affected, just measure it. Always compare it to the other side. So whether you're measuring a finger, you can measure across the carpal bones, you can measure at the wrist. This is a scale that's for pitting edema, and it's really something that you use more for people who they use it in the hospital for people who have congestive heart failure, and you push in, like you've seen people with the ankles that are real swollen, and you push in and your fingerprint stays there. And so that's what this test for pitting edema is. And we usually don't see people who have it that bad in their hands that they leave, the imprint. Sometimes they do. Another way to measure is this figure 8. And this is just a way to measure if the whole hand is swollen. And again, you just do with the tape, do a figure 8 pattern like this. And this kind of explains your starting points and ending points for the figure 8. But another good way to measure swelling. One way that I do it, and this is kind of a way I explain to patients too, is I just look at the number of wrinkles in your hand and compare the other hand. So if you had a rubber glove and it's sitting on the table it's all wrinkled up. Well, the more you blow on it, it goes straight and it doesn't have any wrinkles. So the more swelling you have, the fewer wrinkles you have. And this picture is kind of blurry and hard to see. But if you look at this hand, you see the number of wrinkles on the PIP here, and there's hardly any here. So you'd look at this hand and say, she doesn't have a lot of swelling. But if you look closely, there are fewer wrinkles on this finger. And actually her injury was here, and you can kind of see that there's more swelling there. So just kind of visually looking at the number of wrinkles. The other thing, swelling, if you think of the rubber glove, as we blow it up, there's no wrinkles, but also it goes straight. So when you have a lot of swelling, it makes your hand go straight and it's harder to bend it. Evaluation of scars. If a scar is raised and wide, but still within the borders of the scar, that's called a hypertrophic scar. And keloid scars are scars that move beyond the border of the normal scar. And some people are just more prone to keloids than others. An immature scar is thick and raised and red, and it blanches to touch. And a mature scar is soft and mobile and neutral in color. And you might want to note if the scar is sensitive to touch, or if they're numb. They usually are numb for a long time. That's not necessarily a problem. But where it's a problem is if the scar is sort of stuck. And you see that in flexor tendon injuries a lot, that tendon gets stuck where the scar is. And that's a scar that you need to really work on, a scar that's stuck. Proprioception is kind of the newest thing that everyone's talking about, and you can read about it a lot in journal articles. And proprioception is, basically, position sense. And I know we do that a lot we test it a lot with our stroke patients. But if you think of sensation, it includes thermosensation, which is obviously heat, nociception, which is pain, equilibriumception, mechanoception, and proprioception. And then within proprioception, there are three categories. There's joint position sense, kinesiology, which is movement sense. There's sense of force and sense of velocity. And we have all those senses in proprioception. And obviously, they're important for sports. And proprioceptors are derived from the muscle spindles. There's really no consensus in the literature about tests for proprioception. And I know when I used to see a lot of stroke patients, we would just have them imitate posture. So we'd have them not look, and I'd say, put your other arm in the same position this one's in. Put your other arm in the same position as this one's in. So you might have them not look and say, you raise their thumb and say, put your other thumb in the same position. So imitation of postures. People also do some proprioception testing, having a laser light, and it's also proprioceptive treatment. So you might have a target on the wall and have them take the laser and, move it around. There's also a lot of smartphone apps that are good for proprioception. Like there's a maze that they can do. People are doing a frisbee with marbles for proprioception treatment. So it's kind of the next new thing. And I do think it's something that we forget to look at. I know I forget to look at it. And probably something that you look at more towards the end of treatment when people are really trying to use their hand in functional activities. And, just kind of say that we need to kind of remember, who we are as therapists, and also in occupational therapists in particular, that we're always about function. And even though someone has a broken wrist or they have tennis elbow, it's really what they need to get back to in life, whether it's getting back into, playing tennis or playing golf, or getting back into their work as a landscaper or as a chef or whatever. And we always come back to that. That's our most important goal is, yeah, we got the range of motion, but can they put that together and hit a ball? Can they put that together and hammer a nail? And I think that's where proprioception comes in. And we just need to not forget about taking it to that last part. It's not just enough to get the strength and the motion. We've got to get it back to function. And just talking a little bit, I'm just going to talk briefly about the literature and about evidence and how important it is to look at evidence. And evidence-based treatment is something that's really, it's another thing that they're really talking about in the literature. And in fact, the World Health Organization has an initiative right now, and it's called knowledge translation. And I don't know if you guys have heard about knowledge translation, but what that means is how long does it take something to get from the lab or from evidence into practice? And that's the knowledge translating from lab or from, you know, studies into practice. And does anybody know how long it takes, how many years it takes? It's on the paper. There it is. Can you believe that? 17 years on average for things to get from research into practice. And I think it's something to really think about. And especially for you guys, you're new, you're coming out. And the good thing is that you're going to be open-minded and you're going to be open to new things. And people like me, one of the obstacles to research, you know, to knowledge translation is I do things the way I've always done them because I think I'm good at it and I don't want to learn something new. And I think my way's better because I've always done it the way I do it. And that's where we need, you know, new young people like you guys to understand sensitivity, specificity, to understand the value of those tests and read the literature and to do the treatments that are really evidence-based and to not undertreat, but also not overtreat. And again, the research is showing us more and more that there's some things that we were seeing, like wrist fractures. We just would always see them twice a week for 2 months or 3 months. And maybe the evidence says they don't need that much. So I think our payers are going to start looking at evidence-based medicine, and we have to look at it too. And we have to tailor things to our patients. And if they are doing well, maybe we don't need to see them twice a week. And I'm sure you guys already know this, but this is just the different levels of evidence. And not that these lower levels aren't important, that these aren't important studies, but our best studies are high quality randomized control trials. And if you, and again, you can see a study, you can see one study that says conservative treatment works for trigger finger. You can see another study that says it doesn't. So that's where you look at the systematic reviews and meta-analysis, because what they've done is they've looked at all the studies and put that together. And so you can be a really big part of that knowledge translation, looking at the studies, taking it from evidence into practice, making it a little sooner than 17 years. And this is just a diagram of the levels of the evidence. And again, we're looking for the higher levels. And actually, there are studies that show that between 30 and 40% of the treatments that are provided are not evidence-based and are not that they don't provide any benefit to the patient and are potentially harmful. So these are good reasons, again, to look at the evidence. And just remember that, you know, everything that you read that is printed, that not all of it has value. And so you need to look at a lot of studies. And you need to look at the systematic reviews. So anyway, that's kind of covers it. And I don't know if anybody has any questions or wants to go over anything else. I wish I could get the YouTube to work, but definitely go to YouTube for all these tests because they're really good. Is there anything anybody would like to see again or any questions or anything?
¿Hay alguna pregunta que tengan y yo se la pueda preguntar a Mary? ¿Alguna duda?
Los mormones, un pensamiento religioso que muchos gustan la que se viste así. También son esos rituales que dicen, buenas días, hermana Palma, soy la hermana Alba y quiero darte las buenas nuevas de Dios. En resumidas cuentas, creen en Dios, Cristo y lo que
They say it's all good. Probably they have questions, but you know, they will have like the presentation and all recorded so they can keep searching and all that. Maybe it would be like good if you can send Vero the YouTube videos and we can share them with them. That would be really good. Yeah, they say there were some tests and all that I already explained them to them, like in my class, and then you tell them again so they understood better because they already saw it. Yes.
Yeah. But I think that's the great thing about the times that we're living in is that technology is there. You know, when I was in school, you had to read it and, you know, you couldn't look at some video. So it's great. But
Yeah.
also you guys have to learn so much more, I think, students now. So when you come out, you'll be smarter than all of us because you have to learn so much more.
Yeah, and we have so many resources and we have so many things to learn from. But like the way you say, like maybe in where I'm talking about Mexico, because it's where I'm from, and maybe here we take it from the school to the practice, because we don't have that between make it like the research and all that, because we have to put it into work. Like when I went to USC for an OT program, and I met a girl. She was 32 years old, and she was already doing the CHT, and she was just about to start working. And I was like, what? And I was at that time like 22. And she was like, but you already do everything I'm supposed to start doing. And I was like, yeah. I mean, because
Yeah.
we finished, we start practicing. That's why we
And
have
also,
to learn the right
you know,
way.
people are biased for what they always did. And like I said on that CMC grind, if you asked therapists, they'd say they do CMC grind, even though the literature says the other one's better. If you asked them, because that's the one they've always done. And
Yeah.
I think we're lazy. Maybe we don't want to learn something new, you know?
Oh, and maybe we don't want to do it the right way. Like I told you before, here in the clinics, so many clinics, they don't use the scales, they don't write notes, they don't do all of that.
Wow.
I don't know, but it's very important to have the evidence to do the scales, because that's how you measure the patient's recovery, and so many people don't do it.
Yeah.
So many people don't do it. And
There are
that's why-
plenty of lazy therapists in the US too. Plenty.
Here too.
Okay, anything else?
I think no one has questions. Sí, ya todo bien, Vero.
Sí, Rosa, todo bien. Bueno, muchas gracias, Mary, por todo lo
De nada.
aprendido. Te esperamos en Cancún.
Yeah, we wait for you in Cancun.
Yes, yay. Okay, I got to make my plane reservation. So you got to send me hotel and everything.
Que le tienes que mandarlo del hotel.
Okay.
Ahora mismo.
Tell me what you want me to bring you. Everyone, tell me what you want me to bring. I'll bring a big suitcase.
I'm going to be making my Santa list.
Make your list, please. Por favor.
Thank you so
Mary.
much, Mary.
Buenas
Always-
noches.
It's always a pleasure.
Thank you.
Bye bye.
Likewise.
Good
Bye.
night.
Bye. Chicos, Mary
Thank
es
you.
súper.
Bye.
Thank
Bye.
you.
Here we go.
Chicos, Mary es súper compartida con todo lo que sabe, así que ella, pues, a la asociación nos ha dado varias charlas y nos ha dado cursos. Entonces tenemos algunos de los documentos que ella nos ha mandado, con mucho gusto se los vamos a anexar a su Classroom para que ustedes también tengan esta presentación. Ella se toma el tiempo de ponerla en español para que ustedes pues no batallen en poder estar traduciendo. Entonces la tenemos en inglés y en español, las vamos a subir en los dos idiomas. El día de mañana nos toca capsulitis adhesiva y el profesor es de Ecuador. Entonces, el día de mañana nos vamos a conectar a las 9:30 porque el profesor tiene una charla él es miembro de la Asociación de Codo y Hombro. Entonces tiene una charla, un webinar temprano y a las 9:30 ya está con nosotros. En la clase ha pedido que si tienen oportunidad de tener un paciente ahí con ustedes, pues pueden aprovechar para poder estar haciendo práctica también con él. Y pues esperamos a las 9:30. Lupita, si estás por ahí, puedes mandarles la lista de asistencia para que puedan anotarse e irse saliendo de la charla.
Sí, déjela mando.
Good
Muchas
night.
gracias por todo tu tiempo.
No, de nada. Cuando se
Yes.
ofrezca. Un abrazo.
Bye.
Bye.
Mañana 9:30.
Mañana 9:30. Así es, ahorita lo voy a poner en el grupo. Lo que pasa es que el profesor tiene una charla a las 9, pero a las 9 de Ecuador. Entonces él termina a las 10 de la mañana de Ecuador. Le vamos a dar media hora para que se organice, como que cierre una charla y abra otra. Pero a las 10:30 de Ecuador, él empieza nuestra charla, que son las 9:30 de México. Entonces solo vamos a entrar media hora tarde. ¿Ok? Ahí Lupita ya nos envió la lista.